Good morning to everyone. I hope you can listen to me very well. Okay, perfect. So let's talk today about low-level light therapy in the setting of ocular surgery. I have the pleasure to open this session, and then Dr. Solarino will continue with the other aspects related to the perioperative use of low-level light therapy. So I will present the result of a recent study that we had the pleasure to publish in a British Journal of Ophthalmology, where we described the use of light modulation, low-level light therapy, in 1 week before and 1 week after senile cataract surgery to prevent the onset of iatrogenic dry eye disease. What is the reason for this study? The reason is that we know that a lot of patients undergoing cataract surgery experience after surgery a lot of signs or symptoms that can be very disturbing for patients. They often refer foreign body sensation, burning, stinging, fluctuating vision, and even epiphora. So this is an important topic not only for dry eye specialists, but also for anterior segment surgeons, since we want that our patient has a good vision and also a good comfort after surgery. We know that the problem is that there is no single factor that determine dry eye after cataract surgery, but a lot of factors can variably impair ocular surface with a different extent. For example, lid speculum, or the microscope light, or the drugs that we use before, during, and after surgery. So corneal incision, even if we use a femtosecond laser. So a lot of factors can together works in this direction to determine iatrogenic dry eye disease. And the numbers are huge. If we think about the high number of procedures performed worldwide, we know that about 1/3 of patients can experience in the postoperative setting a variable amount of dry eye disease. And for this reason, we should employ a protocol that can be able to ensure a greater satisfaction of a patient with our surgery. So how this technology, how highlight and low-level light therapy can help us for this task? We know that this technology has different advantages. First of all, it is fast. It lasts 50 minutes. Patient can stay in a chair or in a bed with the eye closed and has a comfort immediately. It is painless. If we think about, for example, intense pulse light, it can be effective in some kinds of patients, but usually it can determine pain during the procedure. In this case, we have a technology that is completely painless. It is very important. And if we want to use it at home, we can also control remotely and allow patients to receive treatments even at home. So different advantages make this technology easy, safe, and effective in this setting. The mechanism of action is complex, but if we want just to cover general aspects of the mechanism of infection, what we can obtain with this technique is the activation of the cellular metabolism, and this determines the release of ATP and CAMP, and this helps cellular metabolism to reactivate and to repair loss of function. The evidence about this technology in the ocular surface setting is very huge. As also in the book we can in the wall we can read that there are a lot of decades of articles published in recent years in the field of ocular surface disease. Here there is a paper from Scientific Reports. Here a paper that our group published in Cornea, but there are different papers, several papers that confirm that this technology is very effective in treating dry eye disease. But what is the paradigm shift that I will talk about? Is switching from dry eye treatment to dry eye prophylaxis. And this is very important because we want to avoid a complication, not to treat a complication that is difficult to be treated and difficult to be solved. We want to prevent it. And this is the aim of our paper that, as I said before, we published a few months ago in British Journal of Ophthalmology. I will briefly describe you the setting and the criteria and the results of this paper. So it was conducted about 2 to 1 year before, and as I said before, the purpose was to assess the effectiveness of the technology in preventing dry eye disease in otherwise healthy patients. This is very important. We did not treat patients with pre-existing dry eye. We are treating a patient that are healthy. They have only cataract surgery. They have only cataract, but no other ocular surface disease. And this is important. We treat patients that are completely healthy. This is a very important aspect for prevention. These are the inclusion criteria. So, senile cataract, no other comorbidity. For example, no diabetes, no autoimmune disease, no glaucoma medications. Patients that are healthy for regarding ocular surface structure. And of course, we excluded also other systemic diseases, systemic drugs that can interfere with ocular surface. Recently, we started using non-invasive diagnostic platforms to study our patients. It is perfect for screening before surgery because we avoid the contact with the ocular surface. We avoid to interfere with ocular surface that we know can have a role if we have to do also biometry or other tests in patients undergoing cataract surgery. In this case, we use the keratograph, but in this booth you can see also MiCheck that can provide you various aspects of dry eye diagnosis. We studied the TR meniscus 8, that is an index of TR production, non-invasive breakup time, that is index of TR stability, we know, infrared meibography, that studied the amount of meibomian glands visible in the tarsus, redness score, and of course also ocular discomfort symptoms for our patients. This is the procedure, as we said before, 15 minutes with a red light with closed eyes. You can test it even here if you want. It's completely painless. And we used, of course, a randomization. This is a 1-to-1 randomization where half patients received a conventional treatment with a red light for 50 minutes, while the remaining half patient underwent shunt treatment. What is shunt treatment? Is a treatment with less than 30% of output that simulate a treatment for both patient and physician. This allows us to conduct a real double-masked study. This is the design of the study. In order to include 153 patients, we had to screen 654 patients because we started to exclude patients with diabetes, exclude patients with autoimmune disease, patient with glaucoma, patient with previous ocular surgery. So we had to remove all confounding factors. And out of more than 600 patients, we could include only 153 patients. At the end, we, of course, had a few lost to follow-up patients, and at the end, we included 131 patients that were randomized 1-to-1 to receive a treatment or a sham. As I said before, we treated the patient 1 week before and 1 week after cataract surgery. And then 1 month after surgery, we evaluate the outcomes of our treatment. In parallel, the sham group received the same timeline for the treatment, but as I said before, it is a treatment without any efficacy on the target cell. It simulates only treatment in order to allow the double masking of the study. This is the demographical characteristic of our population. Of course, median age of more than 70 years, and there was no difference in age and gender distribution between the two groups that was allowed by the randomization. Let's talk about the results. First of all, let's talk about symptom. After treatment, we had an improvement of OSD score, of symptoms of a patient that were treated after 1 month after the treatment. So if we treat patient 1 week before and 1 week after cataract surgery, we can improve their ocular discomfort symptoms. And this improvement was through both 1 week and 1 month after surgery. So even immediately after surgery, just 1 week after surgery, patient reported an improvement of their symptoms. The other most important parameters in dry eye patient is breakup time. Is non-invasive breakup time because it refers to tear stability. And we know that the majority, almost the totality of patients with dry eye disease as an evaporative dry eye disease. And this is a matter of tear stability, not tear production, but tear stability. And with the treatment, we had a significant improvement of non-invasive breakup time 1 month after the treatment. And we obtained these incredible results despite surgery. We know that surgery determines an impairment of ocular surface. If we treat the patient, we not only avoid this decline, but also obtain an improvement of ocular surface, a paradoxical effect. No other changes in the other parameters we had, but there is also an explanation for this. For example, meibomian glands cannot vary in quantity in a so short time interval. We can have changes in the area of meibomian glands over a period of 3, 6, 12 months, but not after a so short period of 1 month. Tear meniscus did not change, but why? Because as you can say, our patient has a normal tear meniscus already at baseline. It's not a matter of quantity, but a matter of stability. And redness is not an issue in our patient. We know that dry eye patient can have inflammation, can have symptoms with a white eye. This is not a direct index of it. Is included in the machine workout, but is not an issue in our dry eye patients. So what we can obtain from these findings, that the prophylactic treatment with low-level light therapy can counteract the detrimental effect of surgery. And so we can not only avoid the decline of parameters, but also to improve the two most important parameters of dry eye, symptoms and tear stability. We are not able to detect changes in meibomian glands, but we know that we need more time to have it. Let's talk about limitation. Have these papers on limitation? Maybe yes. We included a short follow-up duration, 1 month, but we are continuing to study this patient after 3, 6, 12 months, and we will update soon the publication. But the issue is that usually patients come to our office 2 weeks, 3 weeks, 4 weeks after surgery, reporting discomfort symptoms, and with this protocol, we can avoid this. So we know that dry eye disease is an important issue for patients undergoing cataract surgery, and this complication can impair patient satisfaction. These are the unhappy 2020 patients that who see 2020 but are not happy for their surgery. What we can add with this study, that if we perform 2 sessions of low-level light therapy, 1 week before and 1 week after cataract surgery, we can ameliorate tear film stability and ocular discomfort. How this result can affect our routine practice? We think that the prophylactic treatment using low-level light therapy could be easily incorporated in the normal workflow of a patient undergoing cataract surgery. If when in your clinic you see patient, you do preoperative imaging examinations, maybe 1 week, 2 weeks before surgery. Okay, at that time you can do the first preoperative session. Then after surgery, you usually visit the patient 5 days, 7 days, 10 days after cataract surgery. This is a perfect time to repeat another low-level light therapy session. So with this protocol can be incorporated in the normal workflow of the patient without adding other visits, without impair our busy clinic, but can be incorporated in the normal workflow And in this way, we are sure that we can avoid the onset of iatrogenic dry eye. So you can download all the information about the scientific evidence beyond this technology on the through the website. I will be happy to reply to your question at the end of the session if you want, if you have one, or you can write me an email. And for me, it's a pleasure to invite Dr. Solarino to talk about another possible application of this technology in the setting of refractive surgery. That is another very interesting point of our routine and also of this congress. Thank you.
So thank you for being here. It's very important now, I think, also have a focus on the refractive surgery, because the refractive surgery, you know, is a very increasing in numbers all over the world, and there's a special focus for dry eye surgery, dry eye disease, because it's a surgery that involves more the corneal surface than other kind of surgeries like cataract. And more, we will see how those patients will respond to this kind of treatment. The refractive surgery, we can say, is the first in numbers surgery performed after the cataract, that you know is the majority. We can see the numbers. The actual scenario is very interesting, because you see that all the patients that are performing refractive surgery, undergoing refractive surgery, are increasing year over year. Actually, this is an acceleration of the numbers of people that underwent refractive surgery treatments. The number of this increase is more than 5%, it's 6.40%. And we see that is very interesting that it will increase in the next years, because we will see till the 2028 is a continuous growth of numbers. Also, we can see that the patient seeing from a study of the ESCRS are increasing, and the numbers is very high also in 2021. So this is very interesting, because we can see that all those numbers are so high. Actually, we can divide those patients in two main scenarios, because the younger are mainly performing over them, undergoing a treatment like LASIK, photolasic, SMILE, or trans-PRK. There is an increasing quantity of people that is performing the refractive lens extraction, as you can see in the second part of our diagram. And all those people are the people that are in more aged, and those people do perform a different kind of surgery that is more similar in everything, like cataract that Professor Giannaccare already explained us, like problems on the corneal surface. And all the other patients compose a big number, because we can say that actually it's more than 20 million that are have been operated in the world. And actually, we can say the LASIK remain the most performed surgery. The photolasic now is increasing some more, but actually is the most performing surgery on the corneal surface. And we can say that about 700,000 people receive LASIK every year, and so they have to watch their surface, their corneal surface, because there can be a problem over there. If we can say something about the main problems that can be observed in those patients, refractive surgery is one of the main topic that can produce dry eye disease after the operation, and is just before the cataract surgery because it is more dangerous for the corneal surface because there is a cutting of all the nerves, the nerve plexus, the subepithelial plexus, but also the vertical nerves. We must understand also another things because those patients don't come from a normal life, a healthy life like Professor Giannaccare told about cataract patients, because all those patients frequently have less toleration for the contacts, so they would like to change their situation. They would like to underwent a corneal surgery just to leave the contacts and be free of the spectacles. So many times all those patients have a kind of a dry eye disease. So it's very difficult to find a patient that is completely free from disease before the operation. Depending on the kind of contact lenses that was wearing, the RGP lenses which are worse than soft contact lenses, and usually leads to a more evident decrease of the corneal sensitivity. And this is very important. So we can say that the people that usually underwent corneal surgery move from this upper arrow, the pre-op, to the second arrow, the post-op, because they shift towards a lack of production. And so this is very interesting because we saw it clearly during this observation of those patients, because there is a decrease of the tear meniscus, and so we have to keep in count this problem in all those patients. We know that it's very important the kind of surgery that we are performing, because we are cutting completely the epithelial, subepithelial plexus, nerval plexus. Some procedures like SMILE that were defined as less invasive on the nerve plexus really impact as well the same plexus on the vertical nerves that connects all the part of the cornea. So there is no any procedure on the corneal surface that is completely safe for the post-op period, because all those patients, some more, some other a little less, needs to renerve their cornea to get the better corneal sensitivity, to regain the normality, and these take time. They vary from one operation to the other. So we can see that it's very important that we can understand the role of low light LED therapy in make all those patients recovery, not only for the quality of the tears, but also for the sensitivity of the cornea to the completely recover of the corneal sensitivity and the production of the watery part of the tears. Then the nervation we told about this is all the surface that is involved, not only a few parts like is in the cataract surgery, in which actual size of the incision is about 1.8, 2 or 2.2 millimeters, and in which the invasion of the corneal nerves is less important. In those patients, we have a clear cut of all the surface, and so is more crucial the post-op. For example, see the excimer laser cut the corneal nerve, producing a corneal nerve damage. So this lower the blinking and increase the evaporation on the diagram, and we see that also decrease the capacity of produce tears, of tearing, so less aqueous production is a very important part of the dry eye situation in the post-op period. So we can see that about from 20 to 40% of those patients have symptoms of dry eye, and the peaks is very different from each technique to another. Is PRK in the middle, LASIK more important, and femtolasic the same way of LASIK, and the SMILE just a little bit more fast in recovery. But all those patients need time to recover. So if we can increase the quality of the reconjunction of the nerve fibers, the velocity of reconjunction of the nerve fibers, we can increase their comfort, and this is very important. We can see here also the SMILE, the pre-SMILE situation, and the 1 month, 3, 6, till 1 year. It will take about 1 year to reach a level that is similar to the preoperative time, also in SMILE. And SMILE, we can say that is performing better than PRK and than LASIK or femtolasic. And also there is a little bit of difference that is quite obvious, that the younger people recover more rapidly than older people. So this is very interesting, because we are actually thinking that till a few months ago, till a few years ago, that SMILE was a very safe treatment also for the known stiff cornea and the not possibility of ectasia. Actually, we are seeing ectasia in post-SMILE treatments, and we also saw that there is also dry eye disease in the post-SMILE treatments. The ocular surface is quite obvious, that must be taken in consideration before the treatment, especially in refractive patients, because all those patients come from a long period probably of use of our contacts, so they are more poor in quality and quantity of their tear production and tear situation and stability. So we think also that refractive surgery is made of a patient that are high demanding, because they usually see very well with contacts, but they don't want to use both contacts or spectacles anymore. So we want to operate those patients, and for making them happy, they must see very well after the operation in comparison of what was their capacity of see, the visual acuity before the operation with the contacts. So they are high demanding and challenging in the postoperative, because the first 2 weeks people sometimes don't see very well the lower part of our optotype. So for read the small letters, you can add sometimes artificial tear. They immediately read 2 or 3 lines more. What does it mean? This means exactly that they lack in quality and quantity of tear. So tear production, tear stability is deficient in all those patients after the surgery. So we must see where we can act to proper afford this problem, and probably we can act pre and post operatively, because it's not sufficient to do that post operatively. We must anticipate the treatment. As Professor Giannaccare told us, it's very simple to put a mask for 15 minutes during the first access of those people in our office. So we can do that for the first time. Immediately they can appreciate that is very easy. There is no problem about the post-treatment period. Someone referred that he feels better and with more efficient tears stability. They feel better than usual after the first treatment. So we can do that on the pre-operative examination. And we know that actually we made a lot of examination pre-operatively for all those patients. And we can continue post-operatively to treat all those patients. Those patients is so important to prevent the problem, because you can treat the patient when they are already in the first treatment, and so they can recover better. We saw in those patients that the post-operative management was not as we expected, because probably is necessary for those patients to make more treatments for a longer period of time, especially for the tear meniscus. So the quantity of the tears that are produced because of the denervation, we know. So this is how the study was performed. These are previous results. So it's not a large number like you saw for the cataract patient that so well Professor Giannaccare explained to you. So this is a few, but it's very interesting because they differ completely from cataract patients. So we must know that it's possible to prevent the post-refractive surgery with those treatments, and it's important that we do that. We already talked about the low-level light LED therapy. Actually is spreading all over the physical pathologies. We know from eye to others districts is very gaining new frontiers of treatments. It is very interesting because it is the only way in which we can improve the metabolism of the cell, because the direct action of the low light LED therapy is on mitochondria, and mitochondria actually is the engine of the cell. So they produce more ATP, more CATP, and they induce the cell to be more active and probably to overcome the post-operative problems more easily. It's part, otherwise healthy patients in refractive means that all those patients are not on treatments for hypertension, other things, but we know they do have a little bit of dry eye in many cases. And also the first row not so so complete in those refractive patients. The style of the study is exactly the same. We do perform the Sunday questionnaire because it's very simple and it takes less time to be completed in the first office examination of the patient. And you know, the application is very simple. 15 minutes with closed eyes, completely painless. The patient appreciate the post-op and the treatment module that we made is dividing in two to branch the study. One branch in which the people were treated with the real mask, full energy, the other one with less than 30% of the energy, the sham mask. And so we can say that we have a few cases that are very interesting because a lot of them are ameliorating their lipid layer thickness, and this is very interesting. The tear meniscus is a little bit decreased, and then we can see the OSD and the inferior meibomian glands is better. Also, in this other case, we have no important decrease. The only decrease is the OSD fallen down in this patient. And this is another case in which we have a best situation from a treated patient. Here is a comparison in which we have a patient treated with the sham mask. That's very, very important to see that is less than half of the quantity of the tear meniscus. And also the patient is very complaining about his situation. So there is something that stimulates us because the situation is the same of the cataract for a short follow-up, few numbers, very few compared to the cataract study. And also it's important to say that also this patient has a preeminent visual task. So the score of the bias is worse for this problem, but it's worse also because there is a decrease of the tear meniscus. Probably they feel really worse than previous treatments. So we can say that actually in two treatments we have a stabilization of the non-invasive breakup time test. So this leads to a more comfort in patients that are treated. So we can see also that in the OSD. But for the people that are evaluated more in a more longer time. We can say that the meniscus is another focus in which we have to study more. Probably is necessary to prolong the treatment post-operatively, faster recovery for the ocular nerve plexus. And so we are thinking to probably investigate further to 3 to 6 months after surgery, because we need to accelerate to prove that the treatment, low light LED therapy, also act on the corneal reinnervation, and consequently can contribute to normalizing the meniscus. So in this slide that we saw before, we can add that we can treat before, we can add the corneal nerve sensitivity test to test before of the operation, and we can add some more prolong the time of the treatment with the mask after the operation. Thank you for your attention. Thank you so much.
Sometimes patients come to our office complaining symptoms of burning, stinging, redness, and also of fluctuating vision. This is due to an impairment of tear film and ocular surface. So the surgery went very well, but the tear film should be reintegrated, should be treated in order to avoid this complication and avoiding these symptoms. We treated them with this new technology called low-level light therapy. That is a mask that put on the face of the patient with eye closed for 15 minutes. This is a very painless treatment, and our paper showed that we can do a surgery that is very effective and also with a great comfort for our patients.
So refractive patients and also cataract patients have both the same problem, that is to have a high satisfaction after their operation. So we all need to satisfy this need of the patient, and we must take in consideration the pre-op time, because it's the time in which we can add something to ameliorate their post-operative situation. It is actually one of the best things that we can perform on the patient before, to make them heal more properly and more fast. It's very simple to add an examination for the tears, and also the treatment before and after the treatments with LLLT, because low LED light therapy take only 15 minutes time with the patient resting on a chair. All the treatment after the surgery are made usually during the controls that the patient make for stops the therapy and taking care of his situation if there is something that differs from normality.